Well, welcome. Today I am here to share with you some information on all-day positioning and how we can use that with children with disabilities. My name is Mary Miles and I come from White Bear Lake, Minnesota. I have 28 years of experience in PT. I've done a variety of things, started out with adults and then moved to pediatrics fairly quickly. Have done some private practice and rehab, and then am in the school setting now. I've been there for about 15 years, doing a variety of things from birth to 3 up to 18 to 21 years of age. So hopefully I can share with you some of my experience and how I've used that with all-day positioning, and then share with you a little bit of the evidence that's out there to support positioning and why that maybe is more beneficial than doing some standard range of motion. And then hopefully at the end of this course you'll be able to share with your colleagues, and if you're a supplier, share with the therapist why you should do some all-day positioning and what the evidence is out there to support it, and then kind of help with how to find some of that equipment. So who do we need to target with all-day positioning? We really need to target these kids with gross motor functional classification levels 4 and 5, and really get those kids positioned all day long so that we keep their bodies in good shape. And so those are the kids who are using wheelchairs all day long, and we need to make sure we're doing things outside of sitting in a wheelchair so they're not ending up looking like their wheelchair and their bodies are tight. I put this picture in because this little girl is somebody that I worked with in Nicaragua, and hard to tell with the hands, but she had some significant contractures in her hands, and you can see where her foot is turned in. And what happens down there is they really don't have a lot of therapy available, and the therapists that are there are educated more at the level of a PT aide or a PT assistant. Not a lot of equipment, not a lot of resources to help these kids. So this little girl really didn't have a lot of intervention. She's actually 17 years old, so she looks much younger than she is from some malnutrition. And she really didn't have any access to standing positioning and kind of lost a lot of range of motion. So her quality of life and what she can do now is very limited. So if we look at why is all-day positioning important, she's kind of a primary example of why we really need to do it. We need to prevent those kind of contractures. And if we look a little bit at Wolff's Law, that kind of tells us that bone in a healthy person is going to adapt to the changes in the forces that are put on it. So hopefully if we apply that to our kids and we put some weight bearing and loading on these kids and positioning to these kids, hopefully their muscles and their bones are going to grow in the right position that we want them to, because we're keeping them in those positions enough hours of the day to prevent any deformities from happening. And then some other considerations that we're going to talk about today. If we look at kind of the lifespan of kids with cerebral palsy, there's a lot of things that we have to worry about that might happen. We have the hip problems that can happen with these kids, dislocations, subluxations. We have the fractures that can happen from non-trauma things just because we don't have good bone density. And then, of course, as these kids grow, we have a lot of contractures that can happen if we're not being proactive and trying to prevent those things. And when you get contractures starting with these kids, you're going to end up losing some functional skills. So, maybe a child who had been doing some transfers and they start to get tight, they limit their ability to be able to participate in those types of functional tasks. So we'll talk a little bit about that and try to show you some strategies to help with these kids. And then we're going to try to throw in a little bit of evidence that shows us what the research is saying and why we might want to be doing things a certain way, because research supports some of what we're seeing in practice as well. When we look at research, we're going to categorize it. You'll see a lot of the studies that I might share with you are categorized from either a level 1, meaning it is a more rigorous study, and they've used some randomized trials and compared with control groups, down to some studies that are more of a level 5, and those might be more your anecdotal reports and your case studies and case series. And I think they all have some relevance and can share with us some of therapists' personal experience as well as some of that really high, rigorous, standardized research. Before we start talking about positioning, let's look at what types of stretching we do as a therapist. And we kind of look at the traditional passive range of motion that therapists do. And you can see in this picture here kind of your standard hamstring stretching, hip flexor stretching. Got to stretch out those adductors. And I think that still has a place for us to do. We might need to improve some range of motion with some physical therapy. But is that going to maintain things for the long term? We'll take a look at what evidence is saying. There's some active stretching, which is very hard for this level of child to participate with. Our kids who are in wheelchairs are not going to be able to learn an active stretching program that they can carry out. And then I really want to spend the majority of the time talking about what can we do with prolonged stretching. What kind of positions can we help these kids with and help them to get a prolonged stretch that's really going to help their muscle groups and help prevent some of those long-term secondary things that can happen. Okay, if we look at traditional stretching versus doing some positioning kind of from a therapist perspective, I think as therapists, stretching has certainly been a part of our therapy regime for years, and it still has a place for us to do some of that to try to improve range of motion. But I think we want to look a little bit more into, are there other things that we can be doing that will help maintain that stretching, and look at what the research is saying. As therapists, I think stretching for us is, we're really hoping that if we improve range of motion and improve some of that joint range of motion as well as muscular, that we're really going to help kids improve some of their functional ability. So it's kind of the basis behind why we want stretching, to improve functional skills. And then I think long term, those of us who have been out in the field long enough see that if we can do some of this stretching and maintain range of motion, we might be preventing some surgeries down the line. And certainly that's a great thing to be able to do, is avoid some of those surgeries. So let's dig into some of the research and see what we're seeing in the research that would support stretching and prolonged positioning. There's some research done that looked at the effectiveness of some prolonged stretching on kids with positioning. And they reviewed 5 studies that really looked at comparing kids who had a stretching routine, and then they compared the kids who just had some positioning. So the positioning, I like this study because the positioning really looked at using wedges and standers. So not just doing standing, but some other traditional things that we might be doing out in the schools or at home. And it looked at comparing those to see what the effect was of improving range of motion. And really, overall, they saw that with all those studies that sustained stretching is much more preferable to traditional range of motion, because you're going to maintain that range of motion for longer duration. They did see improvements with some of the traditional stretching. What they did was some 40 to 60 second holding of stretches in PT, and they saw some changes with it, but then when they discontinued that PT, these kids got tight again, and they got tight again fairly quickly when they checked them a month later. So I think we have to be thinking about, if we're going to improve range of motion, what will we do for the long term to try to maintain that range of motion? And traditional stretching really doesn't seem to be the answer for that long-term maintenance of range of motion. And there's another study that looked at improving range of motion. They looked at 6 studies. They saw that prolonged stretching through standing will help prevent knee flexion contractures. That's a hugie. I've seen that in my practice, where I can improve knee flexion contractures and then help maintain them if kids are on a regular, rigorous standing program. Not surprisingly, they saw that when standing programs were either reduced or stopped for a while, and even reduced as much of, maybe somebody was standing an hour a day, and then they went down to standing 30 minutes a day, maybe only 3 times a week, they saw a significant decrease in what the range of motion was. So I think we need to really think about educating families that over summer breaks from school therapy, and their typical routines that they really have to maintain a rigorous standing program so these kids don't lose their range of motion. And then looking at what some of the studies are saying on spasticity with doing positioning. The studies are showing that we can reduce the spasticity. Most of the studies have all been done using standers, so they looked at having these kids stand in standers and then measuring what their spasticity level was after they'd been standing for at least 30 minutes. And most of the studies were showing decrease in spasticity, and then there was a study that showed you could maintain these effects of decrease for about 30 minutes after the standing. So that's great information as therapists that we can take and use for how we're going to have, when we're going to have our kids in standers, and what we might do after standing to help them optimize that reduced spasticity. So in my practice, I often will try to pick a time during the day if I have a higher functioning kid who maybe is learning to do some walking in the classroom, or maybe starting to work on walking from a longer distance. If they're walking from the special ed area, maybe down to the lunchroom, we might have them do some standing before they have to do that longer distance walking. So it's kind of a nice thing to know for some of our higher functioning kids if we're going to be able to make effect on how they do some of their functional things during the day. And I think we could carry that over at home. Maybe mom and dad have to do some transferring or just walking in the house. If they do some standing with their child before they have to walk them into the bathroom or walk them into the room for bedtime, it might be more helpful if they were in the stander prior to those activities. And we're going to look a little bit at the effects of doing some positioning on the hips. And I put this little girl in. She's another girl from Nicaragua. They don't, again, like I had said, have a lot of equipment down there. She happened to have a Spica Cast. We were unclear on some of her background on why she got this. She had not had any surgeries, so maybe they suspected that she was going to have problems. It was hard to get a really good background on her medical history from mom, but she had this Spica Cast that she had been sleeping in at night, but we decided to try using it for a stander so we could get her doing some more active activities. And she was someone who actually had pretty good range of motion because she had been in a splint like that. And we were hopeful that if we did a little bit more activity and functional skills while she was in it, that this little girl might progress to doing some more walking. So I think if we look at trying to protect hip integrity in homes, we can look at positioning with trying to keep their hips apart at night, and then look at some positioning that we can do during the day to help with that. I like to share this study from Sweden that they did. I think it's a nice study to look at. They had a large population of kids, 206 kids, and they studied and watched them over a 5-year period. And their purpose with this study was to really proactively try to decrease the incidence of dislocation among these kids who were probably going to be wheelchair users. And what's interesting is it's a little different than what I'm used to where I'm from in the United States, but they did some muscle tenotomies to kind of release some of the tighter muscles, and then they had a protocol of post-operative standing and positioning that they did with these kids, and none of the kids had any sort of a hip dislocation in the 5-year period that they followed them. So we're probably not going to be able to get these kids in for some proactive muscle lengthenings to make sure they don't have hip problems, but we can do a lot as therapists to probably do some stretching during, or some positioning during the day, and get them on wedges with some hip abduction and get them up in standers where they're going to maintain some good hip integrity. And I mentioned earlier that we'd talk a little bit about fractures and how that's affecting kids with cerebral palsy. There's a large group that were followed and looked at to see what their fracture rate was. And this is a good study because it really compared all levels of kids with cerebral palsy. And they found that the higher functioning kids, which are in that level 1 to 3, and those are our kids who are walking independently or maybe walking with walkers or crutches, those kids' fracture rate was very similar to your typical developing children. No increased incidence of fractures. But then if you looked at the lower functioning kids who are in that 4 and 5 level, those are kids who are using wheelchairs. There was some significant things that were really associated with their incidence of fracture, and we're talking about fractures that were not associated with any sort of trauma. So these kids who had some stunted growth and were on G-tubes and then were taking some anti-seizure medications had a higher incidence of developing a fracture in their lifetime. And if you look at some of those things, if you're on a seizure medication, you probably have some decreased absorption of the calcium, and obviously if you're having stunted growth, you're not absorbing and getting the correct nutrients that you need. So I think we need to think about that as we're progressing kids and look at making sure that they get some early nutritional intake and that we get them up and doing some standing to prevent that. Another piece of this study that was really huge was that they looked at if they got these kids in standers who were on feeding tubes or maybe had decreased growth or had some seizure meds that they were taking, they could actually reduce the incidence of fractures by 4 times. So that's huge. If we can get kids up and standing and decrease the incidence of fractures by 4 times, you know, it's a pretty big impact on what their life will be. And then we'll move on to looking at some bone mass density. I think this is a nice study because it gives us a nice baseline of how much should we be standing kids. So this is an adult study that looked at standing patients with spinal cord injuries in the first couple years after their injury. And so we're looking at normal bone here and just seeing what will happen to that bone density if we make sure that they're standing. And so they had these individuals standing for at least an hour a day, and you can see from the chart that 1 year post-injury they were still maintaining nice bone density compared to their control group that didn't stand, and then 2 years later they still were maintaining some nice bone density. So it's that regular loading that is going to maintain that bone density. And even though this was done with some normal bone, normal population, I think we can infer that we would get some of those same benefits for our kids with disabilities if we can get them up and doing some standing. And it gives us a nice parameter for what we should start with, kind of looking at an hour a day and trying to get at least 5 or more days a week. Another study that looked a little bit more inclusively at what the pediatric population is showing for research. They reviewed 6 different pediatric studies and showed some interesting results on their research. The research was mostly showing increases in the vertebral bone mass density versus the long bones. And I think we really want to see increases in bone mass density in those long bones because those are the bones that our kids are fracturing. It's more the tibia and the femur that we're worried about. What was interesting when they added what's kind of considered dynamic standing, so they added either whole body vibration, where there was a system of vibration underneath the stander and they had some movement in the stander. Those kids showed increased bone mass density at their tibia when they measured it. And I think those studies, while they might not have shown as high of bone mass density in those long bones, I went back and was reading how long they had these kids standing, and most of the protocol was 10 minutes a day, 3 to 4 times a week. Well, we talked earlier about trying to get at least an hour a day for normal bone to maintain the bone density, so obviously 10 minutes a day is really not going to improve bone density in these kids. One thing that was interesting too that I think we need to be cognizant as both therapists and suppliers is they found that the ratio of body weight between the right and left sides was really inconsistent, and even the body weight, percentage of body weight that they were weight bearing in standards was pretty inconsistent in some of the studies. So one of the studies did a big research on how much percentage of body weight they were weight bearing, and it ranged anywhere from 23% of their body weight to 102%. So I think as a therapist, knowing that, when I get kids up in standards, I really try to make sure that I do what I call the foot check and make sure that both feet are weight bearing well and I can't move that heel around, and that we feel like we're getting pretty equal weight distribution between the two sides. There's another study that did do a look at some pediatric bone density, kind of known as the Harvard study. And this study wasn't included in that review of the 6 studies, mostly because this was only done in an abstract form, and these researchers never were able to write up the whole study and present it in long form. But I think even if we look at what they said in their abstract, this is another significant study that finally looked at kids and looking to see how much standing do we need to do with kids so that we show bone density improvements. And they followed a group of kids for 9 months, and they asked the parents to have the kids stand 2 hours a day. And the compliance wasn't perfect. That's a lot amount of time to stand every day, but these kids who were standing at least 7.5 hours a week were showing some improvements in bone mass density. So it gives us another supporting factor for where we should start with standing if we really want to target that as a means of improving bone mass density. We talked a little bit in the studies how researchers were seeing that if they were in a dynamic standard, they had a little better improvement in some of the density in those long bones. So I was thinking about how could we implement that in our standards with our kids. Getting some dynamic standards isn't always as easy to get covered and paid for, and it's probably not something that you see traditionally. I do use the sit-to-stand type standards a lot, and if you do some multiple loadings and have kids take a break and sit and then multiply load them back up to standing, we're kind of imitating that dynamic stander mode that you would get from the whole body vibration system. And I think knowing that we need to get at least 60 minutes a day, we don't necessarily have to get that all at once. So if you have a student who maybe can stand for about 20 minutes and then starts to get fatigued and needs a break for their head and neck control, or maybe they're just tight and they need a break after 20 minutes because their hamstrings and hip flexors are stretching too much, you can kind of do multiple amounts of standing to try to hit that targeted 60 minutes a day. Now let's kind of dig into how do we implement all-day positioning and how will that look? And we need to really think about partnershiping with, if we're private therapists, we've got to really partner with the school therapist. We've got to make sure we're partnering with parents at home. I think all 3 settings really need to partner together to make sure that we're all following through and we all have a good idea of what our goals are with positioning. I really look at nighttime a lot, because if you look at how these kids are sleeping, oftentimes they're asleep with their knees pulled up to their chest, and then they're spending a good 8 to 10 hours a day with knee flexion, hip flexion, legs together, maybe even scissored across. And if that's the case and we have kids who are getting increasingly tight hamstrings, we really need to think about how can we implement something into their nighttime routine. This little girl, you can see the picture, she's wearing knee immobilizers at night to really maintain that knee flexion and knee extension so she doesn't get any contractures. It also helps because once you get those knee immobilizers on, you're probably not going to do quite as much hip flexion, and you're going to maintain a little bit more hip flexion and hip extension. And I think it's extremely important to think about doing this early. I work right now with a lot of birth to 3-year-olds, and I'm starting to proactively get these kids sleeping with knee immobilizers when they're just starting to show signs of some hamstring tightness and asymmetries. Because if we can get them into a routine when they're young and they get used to sleeping with those immobilizers on, then it's much easier to carry that throughout their life. If we wait until they're in that late elementary, early middle school years, and they can't tolerate the stretch and they can't tolerate wearing them all night long, it's really hard to fit that into the routine. So I really try to implement some of those things more as a preventative measure in getting kids, maybe we'll wear one on the right side and then the next night we'll wear one on the left side. And that way we're being proactive and we're getting it into their daily routine when they're young, and it is an issue with interfering with their sleep. I'm going to talk a little bit about a case example. I think we can look at evidence and we can talk about what evidence supports, but it's really nice to look at a case where this is what works and what we can do with these kids. Lily is a little girl who is now in 4th grade. She's had a lot of medical things where she's missed bouts of school, and during a lot of those medical incidences she has not been able to get up into a stander because of the medical complications with respiratory. She had surgery early on before she even turned 2 and ended up having to have her hips put back in, and was put into a Spica Cast after that, which is very common to try to maintain that range. Well, she now has become very frog-legged, and this is actually a pretty good picture of her because she can get those knees almost up to her armpits. And so as she's growing, you can imagine if she spends much of her day at home out of her wheelchair laying on the floor and this is her position, it's really been hard to maintain her range of motion. And especially in those long periods where she's missed some school and we can't do a whole lot with what she's doing at home. So when she missed a lot of school, she ended up, she used to be able to transfer with one person into and out of her wheelchair. And for me, that was a really big goal to try to get that back. If we could get her back to transferring with just one person, it'd be just such a higher quality of life. If you have to go from that to 2 people, then you always have to wait for another person to be available to transfer her into out of the chair. And I feel like it gives her a higher quality of life as she grows and moves, and we don't know if someday down the line will she be in a group home and then have to rely on 2 people. You'll probably get better care if you only have to rely on one person to get you in and out of your chair. But kind of a sad fact, but more of a reality. So at school we started doing a lot of positioning where we got her out of her wheelchair and really focused on trying to get those legs straight and those knees together, and seeing where we could go with that. She does have a stander at home, and I would say follow through and consistency with use of that stander is kind of touch and go. Sometimes they use it and sometimes they get too busy. So another example of where we might need to really start earlier with helping these families find a way that they can fit standing into their life so it's more meaningful. Definitely at school she's standing twice a day, and we really couldn't go past 25 to 30 minutes with her in the stander because you can see that she's got a little bit of a knee flexion contracture, and once we got to that 25 to 30 minute timeline, she really would start fussing and she would really be uncomfortable. She also needs to be tipped back a little bit for head control, so it really wasn't an option for her to sit down and work at the desktop of her stander and then go back up to standing again later. So she was someone that we just incorporated standing twice a day to really try to help her regain some of that range of motion. We'll look at some other things we did with her. We did some adaptions on the bike because when she was biking she had lost so much range of motion that she was pretty far out with her legs. So we added a strap around her legs to keep them together, and then just wanted to get her doing some biking to really promote some bone density and active range of motion. She loves movement, so anything that we could do with movement we found was super enjoyable for her. So instead of just having her position, maybe working on reading a book on tape or doing some of her educational learning activities, we would give her some motor time where she could wear her splints, get her legs together, and then be on this wedge and do some swinging on the wedge. And this girl would light up. She loved to spin and go fast, and she'd be somebody who would love an amusement park. Being creative with trying to have her do some sitting in a position where we could keep her legs together and keep her knees straight. When you're in a wheelchair, you're always sitting with that 90 degrees of flexion, and for her, that was, as she kept losing more and more hamstring range of motion, we decided to really spend more time having her sit in different positions that would get more time with that hamstring stretching. So she often went to music class sitting in this chair so that she could be down with the other kids on the floor, yet she'd be getting some good stretching while she was doing it. And then I talked about how much she liked movement. So we were creative with how she could get more movement in her day. And so we would do some scooter board activities, and we'd kind of trade off between whether she'd be on her back, of course with those knee immobilizers again, or whether we would get her on her tummy. When we got her on her tummy, we could also get a little bit of stretching with her arms. As you can imagine, she was not somebody who could do a lot of reaching overhand, so just getting a little bit of stretch to her shoulder girdle was really a nice thing to do in this position. And I think she's different than a lot of kids we have where we're constantly trying to stretch their legs apart, and we were trying to stretch her legs together. So just being creative in as many things that we could do and trying to do it in an enjoyable way. So for her, if we could incorporate movement, she was super happy. Now we're going to switch gears a little bit and talk about maybe a child who's a little bit more of what we would see in our typical caseload. Shaitan is a little guy I work with who has your typical hip flexion, hip adduction, and knee flexion contractures. So he likes to do the scissoring, which is standardly what we see a lot of. He unfortunately had his first hip dislocation when he was in preschool and worked his way back into walking again, and then that hip came back out, and he had a second surgery that really didn't work and failed, and then had a third surgery. So he's kind of had a lot of history for only being a third grader. That's been kind of tough for him. A lot of pain after his second surgery and his third surgery. He's actually somebody who also bent his plate of his that was in his hip and had a fracture of his femur while he was in the Spica Cast after the third surgery. So we had to spend a lot of time really working on getting him back to where he was. He had been walking in a walker with some standby assistance, very short distances. He also has, secondary to his cerebral palsy, he's got some deaf blindness. He has limited vision and a little bit of a hearing loss. So a couple extra things to go along with his scenario. But we really needed to work on regaining some range of motion with him and getting him to trust us and let us move his legs before we could work on getting back to walking. So a couple things that we did with him, he, partly because of his blindness situation and his partial vision that he has, he really likes to pull into flexion and keep his head down on the tray. So we had to really try to find a good way to get his head upright. And he does do a lot of learning through tactile and using his hands and feeling, which made him want to kind of get his face right down into the tray. So we got him into a sit-to-stand stander, knowing that eventually we were going to move towards him being able to do transfers independently and try to regain that skill. And got an eye-to-eye on his head array, which really, it's hard for you to see maybe in this picture, but it is an apparatus that kind of comes down around over your shoulder girdle, and then it's got that little red pummel that comes in between that kind of keeps his head upright. And this has worked wonderful for him. He takes a little bit of time to kind of relax into it, but as soon as he gets that on and feels secure, he does really well with standing. He's another little guy who you get to about 30 minutes, and he lets you know that he stood long enough. And mostly I think what you see is his hamstrings are starting to get uncomfortable and his hip flexors are getting uncomfortable. A lot of trouble trying to regain good hip extension on actually both his hips after surgery. So we really looked at how could we aggressively do some stretching with him. And he was an easier kid as far as being able to do positioning and still really work on his academics because he did so much learning with tactile and using his hands and feeling things. So we could do a lot of prone positioning over a wedge, and you can see we used the abductor wedge. And then he had some schoolwork things in front of him that he was working on identifying. We could use some long sitting with some abduction in the tumble form chair, and then you could see we just put his wheelchair tray on top of there, and he had a nice surface to use for working on some learning activities, and maybe even just give him some free time where he got to use an electronic toy and have a little free time with music. He did a lot of his academics after he started to improve with tolerance of getting some hip abduction using this bolster chair. And so once we got him back into this where he could relax and just had a little seatbelt on for safety so he didn't tip too much, we did a lot of work at this desk because it kept him in really nice position for working. And again, I was talking about the tumble forward chair before. He took this oftentimes to music class as well. He used a manual wheelchair that he could push by himself, but we were really trying to improve his hamstring range of motion and try to get him back to walking. So we really wanted to do more stretching during the day and getting him out of that knee flexion position so we could progress him to standing. And it was very exciting because eventually he got to where as soon as it was time to transfer, he just put his hands out, put his hands on my shoulder, pulled himself up to stand and started doing a transfer. And now he's back to getting up in his walker and taking about 10 to 20 steps, and he can go about 10 to 15 feet with that walker and a little bit of standby help. So we've come a long way with him, but we had to just be very aggressive on how we did the positioning and really not use his wheelchair for a whole lot of his school day so that we could really get him back to where he needed to be. So if we look in summary, the things that we really need to think about with these kids for positioning all day long, it's super important to start them early. If we don't start these kids really early, we're going to kind of miss the boat where we can fit it into the routine. So you can see this little guy is in a corner chair where he's sitting with some knee immobilizers on and then working on stretching his legs apart. And he is only an 18-month-old. So I'm seeing already that he has a tendency to have tight hamstrings, and he has a tendency to want to scissors across. And he's not always like that, but it's enough where we really want to start implementing these things early so that he gets used to it and he doesn't have issues with getting tightness and range of motion and possibly tight muscles that are pulling his hips out. We talked a little bit about Wolff's Law, and if you think about a hip socket and then there's your hip, and if you have those tight muscles pulling your hip across and they're abnormal in tone, you're kind of pulling that hip right out of the socket. So if we can do positioning like in this chair and in the stander and keep those hips at least neutral or even get some abduction and your hip away a little bit, you can see that we're pushing that hip back into the socket and hopefully helping develop a better hip socket. And we got to start early because we got to get this little kiddo. He's up in a stander every day and he's doing some positioning in this chair when he's working on some fine motor skills, and he's working on his head control. And then he wears a knee immobilizer. He switches off between the right and left legs every night to help him. And just like I mentioned, we really don't want to forget that nighttime intervention. This little girl is now in middle school, so this picture might be a couple years old, but she started off very early when she was in late preschool years and started wearing one knee immobilizer at night and switching between the left and right legs. And now she's kind of entering middle school years and starting to grow a little faster and going through growth spurts, so she's actually wearing both of them every night. And here's her mom putting them on and getting her ready for her nighttime routine. So it's just become a part of this family's routine that this is what she wears at night. And they started early and they're still doing it 6 years later, so it's a testament to trying to figure out those times and getting it into the pattern so that parents are comfortable with it. And actually she sleeps really well with them on, and it doesn't interfere her sleep because we started when she was pretty young before she got so tight that she couldn't handle them. I didn't talk a whole lot about where to get equipment. For those suppliers who are in the room, a lot of times I do get my immobilizers from the orthotist when kids go get fitted for their no AFOs, but I know I've also bought them from suppliers, so you guys should have access to being able to measure and fit these kids for some knee immobilizers to help them. It's always covered by insurance. Sometimes it's harder to get those things like adapted wedges and equipment like that to position kids at home. And I've had some pretty good luck with, in Minnesota we have a lot of our kids on some waiver programs where as a therapist I can write a letter and just describe what this is going to help them with and how it can functionally help them. And then we're able to get some of those things approved and paid for by those waiver programs. And then you have to be creative, for there's a lot of kids that aren't on waiver programs and accessories that will help pay for that stuff. But if you check with your local children's hospitals, I know we have a couple different programs in my area where you can apply for a grant, and one of our children's hospitals will give kids up to $1,000 towards a mobility piece of equipment that will help them. So a lot of kids have been able to apply for these, some help with covering their adapted bikes. And adapted bikes can be expensive, but getting that baseline to help you with a little bit, and even looking sometimes on the medical resale sites, your Craigslist and those kind of places, you might find some used equipment that you can purchase to use at home. And if you can't purchase those things, then as therapists, we just have to be really creative on using pillows and maybe the boppy pillows that infants use to help us with doing some positioning, figuring out ways to use maybe some weighted blankets or heavier blankets. I've even used some barbell weights to try to help keep kids positioned, making sure that we have something soft in between the barbell and their hip. And Velcro straps are great. You can keep so many things together if you have some good straps. So I think just really working with your suppliers to help you get, obviously standers, you'll be able to get those through your suppliers, and they can help you choose the best stander for your client and really get the accessories you need to get them positioned well. And then some of those other things, working with your suppliers to try to find those items. And hopefully that gives you a good idea of how to start kids with positioning all day long and why we should be doing that. I think the research is out there, and I'm giving you a reference list, so if you want to go back and look at any of those. But I think we can use our therapist knowledge and our experience that we have and combine it with some of the evidence. And I think using some of that evidence to educate parents on why they should be using this equipment and how it might help their kids down the line will get us a long way in getting some carryover at home. Thank you.